Thank you, Dia. I couldn't have asked for a more power pack panel to kick off the conference. The topic is very aptly healthcare for all, delivering high quality, affordable healthcare for Bharat. When I think of the topic instinctively, my reaction, as I assume the reaction for many of you, is to associate that topic with Ayushman Bharat, or Modi Care, as it was called in its initial days. The most ambitious by far healthcare insurance scheme in the world, covering 700 million lives, with a 5 lakh insurance cover, including for very complex quaternary care procedures. The program has been supported by the government's goals to push up medical education infrastructure, and also another very ambitious scheme in the National Digital Health Mission, which seeks to create a uniform tech backbone for healthcare in the country. And if it is implemented per the aspiration, India will be one of very few countries which is truly interoperable when it comes to healthcare data. But what I miss out, unfortunately and unfairly, is the role of the private sector and especially the startup community in driving this healthcare for all agenda. Through the pandemic and beyond, we have seen very exciting models around remote consultations and remote diagnostics for triaging the patient from primary care to secondary and tertiary care, or triaging a patient from the smallest towns to the larger metros. We've seen delivery of medicines and diagnostics to the most remote parts of the country because of digitization of supply chain infrastructure. And you've seen very rapid growth in private insurance coverage, often through unique models around early interventions and care for the patient so that the patient is kept out of the hospital. Again, as I keep saying, none of these come without their share of challenges on the ground. But I think it's really worthwhile taking a moment to acknowledge what we think are the beginnings of a transformation in the healthcare sector in the country. So to talk about this, we've curated a very unique panel of experts. We couldn't have found a better panel. We have one of the key architects of the Ayushman Bharat program. We have a world-renowned economist who is credited with reforming the financial system and now has set his eyes on the healthcare system in the country. And we have two experienced operators who represent different geographical sections. One, the metros and the large cities, and then the other, the rest of the country. So let's start with the most visible manifestation of this agenda, which is Ayushman Bharat. And so no one better to talk about it than you, Dr. Bhushan. And as you reminded me, this program is still less than 5 years old. As you look back, what is your scorecard for Ayushman Bharat?
So, thank you, Prem, and thank you for inviting me today. Actually, on 23rd of September, this month, we'll complete 5 years. And I just wrote a message to, they are having a big celebration, so I wrote a message and looked at the numbers. And I myself was astounded by the achievement so far in the scheme. Within less than 5 years, close to 6 crores, that's 60 million treatments have been given. And 50,000 treatments are being given every day. And if you'd asked me when we were starting the scheme 5 years ago, that within 5 years, are we going to have 50,000 treatments every day, probably I would have taken it. And the story is still not finished. Also, the government has put in, government meaning central government and state governments together, 65,000 crores into this scheme. And our calculations from the government are that while government has put in 65,000 crores, uh, they have saved more than a lakh crores for the people, because they have negotiated good rates. Had they gone on their own, negotiated on their own, they would have spent more than a lakh crores. And by even conservative estimate, I think millions of families have been saved becoming destitute. They now have brighter future. They've been saved that self-respect. And so in that sense, I think I would give this an A+. But again, these are the visible numbers that this Ayushman Bharat, Pradhan Mantri Jan Arogya Yojana, you can see. But there are things that you can't see and probably can't quantify, which have happened because of Ayushman Bharat. And I will not go into all of them because I think others should talk about it. But just quickly, 4 things that have happened because of Ayushman Bharat. One is that, it has given a framework for covering populations for curative health. And there are 6 states which have used this framework to actually expand the coverage to all, and they've covered entire population using the framework that was provided by Ayushman Bharat PMJ. So, and in times to come, now since they have this a proof of concept, this can be used very easily, and other states, once they have the capacity and resources, can expand it very easily. Second thing, I think you referred to that in your opening remarks, Prem, that PMJ is an end-to-end cashless and paperless scheme, and it's so that actually provided a strong foundation for digital health. And the reason that National Health Authority, which is implementing PMJ, was asked to implement also National Digital Health Mission was that we were already doing that. We were digitizing all the treatments. We were providing a treatment based on IT system. We had unique ID for each of 500 million people. We had ID for hospitals. We were also dealing with the insurance companies in terms of in a cashless manner. So in that sense, that was that has provided that strong basis for digital health. And which third thing that which is done, I think again you refer to that, is that it has deepened health insurance, concept of health insurance in the country. We have more than 26,000 hospitals, and most of them, and at least large proportion of them, have never used insurance. They've always used cash, they've used fee for service, and so this kind of confidence that they have now, they have that they can provide services and someone is going to pay, third party is going to pay them later, is coming now, and so we have a much better basis for expanding health insurance. And lastly, I think I'll be looking forward to hearing from Suchin, is that it has also given that incentive for private sector to invest in tier 2 and tier 3 cities. Earlier, the issue was that there was no demand, or demand was not sufficient in rural areas, and because people didn't have paying capacity. Now, because of Ayushman Bharat, there is a demand, and our hypothesis was that because of that demand, supply will respond, and there'll be more hospitals coming up, and we are seeing that now that there is a response in that supply and expansion of quality services which are affordable in tier 2 and tier 3 cities. Thank you.
Thank you, Dr. Bhushan. And I was going to say, be careful what you ask for, because with this panel, I can assure you, you will get cutting edge insights, but don't expect the panelists to agree with each other, which will make it even more exciting. But if you listen carefully to what's said, and more importantly to the unsaid, I think you will walk away with 2 or 3 opportunities for new companies, that's for sure. So your wish is my command, Dr. Bhushan. We will go to Dr. Suchin, who runs a chain of hospitals. He's the co-founder of Ujala Cygnus, which is a chain that predominantly focuses on the tier 2, tier 3 uh, cities and towns in the country. And your chain, in many ways, Dr. Suchin, has been a beneficiary on two fronts. Post pandemic, number one, people wanting to stay back in their hometown for treatment as opposed to previously wanting to go to a Delhi or a Chandigarh for treatment. And number two, government insurance schemes and Ayushman Bharat. Has Ayushman Bharat been a tailwind or a headwind?
Thank you very much, Prem. And thank you for having me here as well. Uh, our organization was built on some personal stories, on the ethos that no one should die while trying to access healthcare because of either financial reasons or geographical reasons. It was built due to some personal stories. So the fact that we treat each and every person coming into the door, now that with Ayushman Bharat, there is, as Dr. Indubhushan said, someone who will pay for them, rather than earlier when you were wondering where they will get their payment from, whether they'll be forced to sell their lands or sell their houses. We know that 6 crore people slip below the poverty line every year in India just due to healthcare costs. And we also have to realize that in India, healthcare is not just underserved. It's not just that we are not having doctors or hospitals in those small towns, it is under-accessed also. Our surgical rates are one of the lowest in the world. So the Lancet Commission for Global Surgery, and I'm sure Dr. Moore can tell us more about it, estimates that for a country, LMIC country like India, we should be having about 5,000 surgeries per 100,000 population per year. Brazil has more than 14,000. Countries which are in the Nordic countries like Norway or Sweden, even Belgium, they have numbers which are closer to 23,000 per 100,000 per year because the awareness is so high and the out-of-pocket expense is so low. But in India, if you see last year, I think we did about 2 crore surgeries in all, which is the number is less than 1,500 per 100,000. So the rest 3,500 are not having those surgeries at all, right? They don't even know that a cataract surgery within 5 minutes can restore their vision. That is why India has the highest number of preventable blinds in the world. They don't know that a joint replacement can make them walk again. So in a will have to keep in mind that unfortunately Ayushman Bharat has been equated with only one limb of the program, which is the PMJY, which is the Pradhan Mantri Jan Arogya Yojana, which is the insurance part. We completely forget that there was supposed to be a huge part of it called the health and wellness centers, which focused on the preventive and primary care, and nobody talks about it at all, right? And I hope the National Digital Health Mission will contribute to that a lot, because the 65,000 crores that sir said, the 1 lakh crore number, that is unfortunately only the direct cost of the disease. We forget to measure the indirect cost and the intangible costs of the disease, which are actually the scariest costs, right? A patient comes to us with kidney failure. We know there are 70 million diabetics in India. We know that 1/3 of them will go into kidney failure for sure. We are amputating 1 foot every minute due to diabetic gangrene, right? So patient comes to us, we amputate the foot or we put them on dialysis, we can pat ourselves on our backs, the oh, we saved you 10,000 rupees or a lakh rupees, which you would have spent if you'd gone to Delhi to get this done. But then because you're on dialysis continuously, you don't have a leg, you're out of a job. So your future earnings that are lost run into lakhs and lakhs of rupees, which nobody is counting. And because now you're out of job, you'll pull your children out of school and start sending them to work, which is the intangible cost. So future many generations will be gone because you could not control your diabetes upfront. So Ayushman is a tailwind for hospital chains like us, which focus on low cost treatments, which have conclusively proven that even at these rates we can be profitable. We've been champions of Ayushman Bharat ever since it was launched. We were the first ones to get impaneled, even in states which have not yet accepted the Ayushman scheme. The first mitral valve surgery was done in one of our hospitals. We were recognized throughout by the government. Out of the first 10 hospitals in the country that were given the golden cards for good treatment, 4 of the hospitals were ours. But I think just a fee-for-service model and an insurance model, it will not really help the community in all. That's a different topic to discuss altogether. But I think NDHM coming in and being propagated widely will help a lot of those things to be sorted.
We'll come back to that. But compare and contrast, we'll jump to Joy. Joy Chakrabarti runs a very well-reputed health system in Mumbai called Hinduja Healthcare, but also has a very good sense of the issues and the opportunities facing hospitals in metros and larger cities. How do they view the Ayushman Bharat scheme, Joy?
Thank you, Prem, and thanks for the invitation. After hearing him as well as our Suchin, I feel I am the bad boy sitting here. So
that's why we got you.
So I'll tell you that during my higher education as well as when I started my career, probably all of us were looking at, and our aspiration was to see a scheme like Ayushman Bharat is in place in this country. The reason is we have seen success stories across the world, similar kind of thing. And I remember in 2018 beginning, when this thing was getting introduced, and a lot of time we used to interact with Dr. Indubhushan, and he used to tell us, we are quite excited and we are very much enthusiastic with a lot of concern that what it is ultimately going to take shape. And when it got introduced, we thought that it is going to be imposed, or it is going to be, asked to all of us to take the schemes in our hospital. But over a period of 5 years, we are going to, complete the 5 years of this Ayushman Bharat introduction. It has not happened. Now, question is, how do we look at it? We look at the scheme definitely with a lot of respect, the numbers, the kind of, costs it involves for a particular surgery, the way Tier 2, Tier 3 cities, hospitals have been benefited, it is really remarkable. But when you come to hospital like ours in Metro, and especially if I talk about Mumbai, we all look at some of the economics, right? So in Mumbai, I'm sure those who are not from Bombay may not be knowing, we already have some sorts of free or subsidized scheme which are running in hospital like ours. So in Bombay, if you see all big hospitals barring 1 or 2, all falls under not-for-profit charitable category. When we fall under this not-for-profit charitable category, 10% of our beds are supposed to be kept for completely free treatment. And 10% are at 50% subsidized treatment cost. And on the top of that, we have bodies like Charity Commissioner who looks at it, and now the system of daily updation of the data through net, and then they look at it monthly, they visit hospitals, they scrutinize this. Now when you have in one hand this kind of mechanism where you are monitored and you are supposed to do, and with a lot of honesty I can tell you, we don't get the right deserving patient in most of the cases under this scheme. The reason is, the documentation or the kind of credentials they bring, all are fake and it is cooked up, but we don't have much to do. So that is hitting us in terms of our bottom line. Now on the top of that, when this Ayushman Bharat came, it came definitely with certain prices. It is not free or something. we have seen a huge difference in opinion amongst the metro cities depending upon the geography. When you come and think about Mumbai, probably the treatment cost is one of the highest in the city, in the country. And when we have that, in one hand, we are doing so much of subsidized care, and at the same time, your cost of treatment care is so high. Along with that, getting this Ayushman Bharat accepted in your own hospital and getting it running becomes a very difficult and challenging task. So to come back to your question specifically, hospitals started avoiding and started looking at it that how do you, try to keep yourself away from all this, because we looked at that the reimbursement what happens through Ayushman Bharat, is it at least going to meet your the expense what you're going to incur, even if it is not giving you the value addition in terms of your top line. So we have found that it is not meeting that, and at the same time, under the scheme of this charity commissioner and the free treatment what we give, doctors and everybody are supposed to be paid for that. So there is a money which is flowing from the hospital kitty to the professionals. But in case of this, if it would have been introduced, things would have been further difficult for us. And as a result of that, most of the hospitals in the metro cities have kept themselves away, may not have actively got involved, though I can tell you it is a big blessings for the people who are in tier 2, tier 3, or even in the rural area, which they have been empowered to avail treatment care without doing much with the help of the government.
Understood. And you make an interesting point, Joy, around the fact that the rates are often, at least for a metro and a large city, not conducive to running a sustainable operation and a sustainable business. If it's okay, Dr. Suchin, I'll come back to you, for a few minutes, because as you have implemented Ayushman Bharat and the government schemes, you've managed to do it at scheme rates and yet generate a very profitable business. What have you done operationally? Can you give us a few examples of what have you done operationally to be quote unquote fit for purpose for Ayushman Bharat and the government scheme? I think that will be quite useful perspective.
So, see, we have to clearly acknowledge that the rates of Ayushman Bharat are amongst the lowest in the world. There is no doubting that. And you need to create a very different business model completely. You cannot have the traditional fee for service, sharing with star doctors, low volume, high cost model that private healthcare has traditionally followed over the years. It has traditionally been this model. You need to flip the model completely to a high volume, low cost, and no sharing with anyone. So operationally what we do is all our doctors are on fixed salary basis, mostly 90% to 95% of their payouts are fixed. They have a very, very small variable component. So financially what it helps us in doing is once we hit a certain volume of patients, once a certain Rubicon is crossed, then almost 50% of the top line starts flowing into the bottom line. It also helps us in two ways in fulfilling the ethos of the organization. One is that the doctor is not really worried whether the patient will pay or not. They focus solely on their clinical work. So if at 3 o'clock in the morning a heart attack patient is coming, the cardiologist will not ask, does the patient have money to pay? Should I come and put in a stent? She will go and put in the stent regardless of what happens because she is on a fixed pay model. And second, it disincentivizes unethical behavior and unnecessary interventions a lot because doctors are not getting anything to do it. So these three things are fulfilled. Second, the use of generic medicines and consumables is non-negotiable for cases like these. You have to have a very strict control on the formulary. And again, not having star doctors, I'm a doctor myself, but I tell you, doctors are some of the most difficult people to work with. They're like superstars. They don't have god complexes. They are actual gods in themselves. If you have a cardiologist who's the only cardiologist in the district and working in your hospital, it is really difficult to keep them happy all the time. So not having the really superstar senior doctors helps us a lot to make sure that they stick to the formulary that is decided by us in the beginning of the year, both of us sitting together, and then making sure that we are very efficient on operations. So schemes like these, which give you a package rate, force you to be extremely high quality clinical work and very efficient, because if you treat a patient coming in and discharge them in 2 days in and out, you get exactly the same amount of money. If you were to complicate that patient, have a surgical site infection, keep the patient for 10 days, put him in OT 3 times, take him back, you will get exactly the same amount of money. So making sure that there are no complications, there are no surgical site infections, the patient outcomes are of the highest possible standards, these kinds of schemes force you to do that. And I think in the end, it works out well for everyone. So operationally, you have to do a lot of these things to make sure that
What
you are...
about the capex?
The initial capex also, I think, for enabling return on capital, you have to be very cognizant of what exactly you are going to do and not gold plate your assets unnecessarily. So for example, in our small towns, we understand that neurosurgically, we won't be doing deep tumors or very complicated brain tumor surgeries. So 4 to 16 slice CT is enough for us. We don't really want a 256 slice CT unnecessarily. So these kinds of things you have to decide, sit with the consultants, exactly decide which is the community you're going to address, what kind of disease profile they have, what are the treatments you're going to offer, and equip your hospital exactly for that, no more, no less.
Dr. Bhushan, you had a thought?
You know, I've been to large number of conferences like this, and each one of them, the issue of prices has come up, because that's a very sensitive issue in terms of, and I have not heard of any hospital, private hospital, saying that our prices are good, and of course they want more and more, and so our response has been just the same for last 5 years. Whenever I say that, when we started this, we didn't have a lot of database. We have other schemes like CGHS and others, but those schemes also don't have any analysis which can lead us that for this package, this health condition, this much is the right rate. And also that's not feasible, because we are a huge country, and what is true in Mumbai is not true in, say, Jaunpur in Uttar Pradesh, right? So there has to be a huge difference. And so catering to that kind of heterogeneity in the country was a challenge, and collecting data was a challenge. But over last 5 years, I think the scheme also has evolved in terms of having differentiated rates across different kind of hospitals, differentiated rates across different geographies, and also new innovations. Like earlier, when we started, for a package for a health condition, it was a fixed rate that 80,000 rupees for, say, total knee replacement. But now it's a much more nuanced pricing, and it's a combination of fee for service and fixed rate. And for devices, there's a separate rate, so that because once you package everything together, they can be incentive to use low quality device, because here now we have separate rates for devices as compared to procedures. So I think that kind of innovations are taking place. And I think NHA is open to the idea that if you provide them more data and reliable data, credible data, they will be open to also changing or increasing rates as possible. The first revision that I did after about 1 year of the scheme, we actually reduced rates for something because we found out that those rates were too high. And in some states, rates were so high, and this is an example from Gujarat, that they were paying 50% more for total knee replacement as compared to other states. And with the result that about 60% of total knee replacement in the country were happening in Gujarat. And they were sending out scouts to get people for total knee replacement, new hospitals were coming up just to cater to that, and they were going to actually neighboring states because national portability is allowed in this scheme. So they were getting patients from MP for those, and with the slightly where the knee replacement was not required, it was being given. So I think also rates have to be very, it's a sweet spot that we have to do so that we don't have very high rates which give perverse incentive for supply-driven demand. But at the same time, they should not be low so that there is no, those treatments are not feasible for the private sector.
Got it. Thank you. Dr. Nachiket Moore, world-renowned
from all three of the panelists and from you, Prem, and I'm very pleased to be here. Health for all, as you know, in India, from 1948 onwards, has been the goal, as it were. Repeated commissions, repeated committees, including some in which I contributed to the volumes of books sitting on people's shelves, has been the goal. Unfortunately, the pathway is not totally clear where we go with it. Some elements are becoming clearer. One of the reasons I'm excited about PMJY, frankly, I'm less excited about it as a scheme. I'm much more excited about it as the power that, Dr. Indubhushan, in fact, personally, when he got involved, of the design that was built to affect purchasing of healthcare. We know from worldwide experience, one of the reasons why hospitals are currently taking the view that rates are low. If you look at the Swiss experience of Lamal, when the whole switch happened to insurance toward universal care, this was a universal refrain. Prices are too low. Japan runs a highly price controlled system. Daily bed rates are controlled, and everything is controlled. There's no room at all. If you have a 1 square inch bandage, you get paid some fixed amount. It's 2 square inches, you get fixed. It's a big blue book that decides what to do. The sector innovated. I was so pleased to hear from Dr. Bajaj what he has done. I love his idea, you can't have infection. Because the minute you have infection, you have to keep the patient there. And if that is what is producing Dr. Bhushan's work, that's terrific. Now, my research shows, and we have a new paper that came out a few months ago in the Lancet, in which we find that because India has such a powerful value to cost ratio, just to give you an example, a nurse costs 80,000 US per year in the US. In India, the same nurse, give or take, 2 lakh rupees, implying an exchange rate of 3 rupees to the dollar. Not 22 rupees of IMF and not 80 rupees of the market. Many of these states, in fact, there are 12 states, where current government expenditure is adequate for universal healthcare. Now, you might say, if there is enough money, why are we not seeing universal healthcare? Kerala, I was discussing with somebody, has today diabetes rates in 2 of its districts that have crossed 20% and rising rapidly. At 35%, you will walk down the street in those districts, you'll see amputees. It will become an epidemic of people with blindness, strokes, because it's a very, very large number of people that are showing diabetes. So you might say, well, if they have enough money, why are they not? The key piece missing is they're not using the money they are spending well, because they don't have the purchasing capability that a scheme like Ayushman Bharat actually enables them. Today, it is all what we call line item budgeting. There are over 15,000 line items that are used, how many gloves you have, how many syringes you have. And it came to us from Nikolai Alexandrovich Semashko, Stalin's health minister. What was the concern Dr. Alexandrovich had is that your own staff will seal your syringes. So control what happens to that. Forget outcomes to people. There are lots of people, if a few die, it doesn't matter. What matters a lot is gloves should not be lost. That was the underlying thinking. From that to what Dr. Bhushan said, outcome-based. From starting to think about what to do. Now, in theory, it's very good. But in practice, to make it work, that's been a real nightmare for many countries. And what we are discovering from research, including in a highly left-wing country like Vietnam, they have switched out of budget-based payments to their own hospitals. It's all become insurance-style payments. I'm very excited about the capacity that's been built because the volumes, while the numbers in India, all numbers are good, the reality is 65,000 crores is a great number, but in that time period, the country spent 35 lakh crores. Right? This is a tiny number, 0.03, 0.04% of GDP is total allocation to Ayushman Bharat. At that amount of money, I doubt we will find any direct impact. But indirect impact on infection controls, on how government hospitals receiving Ayushman Bharat money are doing relative to those government hospitals that are not receiving Ayushman Bharat money. The discipline that comes up, the quality of service that's there, the availability of the doctor changes quite a lot. And I think that clearly is an important direction we will have to go. And schemes like this, I think, enable that to us. Now, obviously, as was pointed out earlier, it's not enough. In fact, there are clear dangers here. When Lyndon Johnson signed into Act Medicare, Medicaid, he made the same error that we have made with PMJY, which is built out a fee-for-service model in which government is paying. Today, it is not adequately funded, so you're not seeing the inflation spiral. US government spends 8% of GDP on healthcare. With that 8%, it can serve only 40% of the population. Right? You know, countries like the UK are spending 6% of their GDP, which is smaller than that of the US, but are able to cover 100% of the population. Why is this? Because Medicare, Medicaid, PMJY-like scheme, produced a inflation spiral where every hospital said, I need more money, every doctor said, I need to be paid more, and it just went out of control. And this was something that Mark Pauly, 1968, had warned will happen. The minute you introduce insurance, what happens? At the point of consumption, the good is free. What in any good this happens? You see this in insurance, the knee surgery that was spoken about, demand goes up. You know, the supply-demand economics that you see in regular markets doesn't operate here. So you get excess demand, excess supply, and the market is starting to show that evidence as insurance starts to expand, unless you rethink what are you going to do about other aspects of this care, this whole value-based care, all this stuff that is going on in the US. US used to be indemnity-based insurance 80% 30 years ago. Today is 97% managed care. Because everybody has realized that if you don't control all of the pieces that Dr. Bajaj said at early stage, you're going to get flooded. What happened in COVID to us? Because we couldn't and we didn't control the disease progression at the primary care level, our hospitals got flooded. Now, if I give you diabetics at 35% in the city of Bombay, no hospital system in the world.
So how would you, if you were to reimagine what the healthcare system would look like to, in some ways, complement Ayushman Bharat, what changes are needed at the primary health level?
So let me take a specific example, like a state like Kerala.
Maybe Nachiket, if you can speak close.
Sorry. Kerala has wonderful primary care, wonderful secondary care, wonderful tertiary care. Challenge is, primary care is virtually empty. There are no patients. One patient a week, one patient a month, very low utilization. Right? Hospitals are full as if there is no tomorrow. You go and talk to a hospital line, and some of the hospitals actually did this. Talk to patients. Why are you here? All primary care diseases. Right? They are not there for something that the hospital needs to do. Tertiary care hospitals are doing routine deliveries. That's not their role. They should be doing liver transplants only, or dealing with 700-gram babies. Why is a 2.5 kilo baby that delivered spontaneously in 30 minutes coming to a large hospital system? The system has gone and migrated up there. What I would do is talk to Kerala government, Goa government, Delhi government, and say, go to NHA and say to them, here is my entire health budget, not the 0.05% of GDP, 100% of what I'm spending, I'm giving NHA. Now you buy all healthcare for me, ideally from the public sector, but if the public sector is unable to do it, then bring in the private sector as needed. Today, Kerala is doing C-sections like there is no tomorrow. 50, 60, 70% babies are being born against a benchmark of 15%. And not just the private sector, the public sector is doing this. So while on the one hand you have no primary care, and you are sitting with one of the highest burdens of diabetes in the world, you are doing C-sections which are not needed. A PMJY will start to monitor this, push this, put gatekeeping. Why is the NDHM automation not a possibility for Kerala? To say to individuals in villages, you cannot show up at a hospital unless you have been seen at a primary care center. You cannot bypass this center. Thailand has what they call double gatekeeping. Primary care will send you up, tertiary care will send you back, will not let you enter the hospital, and will say, no, sorry, you are not required here. This needs automation. This needs purchasing capabilities, needs design. We did a study when I was in another organization of one of the states, in which we looked at how is budget allocation happening in districts of the state. It turned out the only time it happened was in 1947. Since then, it is 5% of the previous year's budget. That is explaining to you the 2005 budget. The disease burden on the ground has gone completely all right, completely different. But it's that 1947 number plus 5% every year is giving you the 2005 number.
I'll come back to you, Nachiket. Dr. Bhushan, do you agree in terms of how would you, this whole primary care, and how do you make sure that you're triaging it? How do you make sure that the whole system is working? What more can be done, both at the Ayushman Bharat level and beyond?
Dr. Bajaj referred to that. Ayushman Bharat has two legs. One is health and wellness centers, and government has created more than now 150,000 health and wellness centers, and each health and wellness center covering a population of 5,000. And one of the weak points of our scheme has been this loose connection between health and wellness center and PMJ. Ideally, and there has been a lot of work being done and was done on this, is that health and wellness centers with expanded role on primary health care and expanded staffing and budget would play big role or bigger role in terms of screening of population for major non-communicable diseases, health education, and many others. And during the screening, if they find that, for example, so many people have likely cancer, and so they should be referred and they should be found places. If they are from Ayushman Bharat, PMJ, then of course they should be sent to impaneled hospitals. And once the treatment has been given and they're discharged, like Nachiket was saying, they should be referred back to a health and wellness center, because many of these health conditions would require lifelong treatment. If you have heart surgery, and probably you have to take medication all your lives, right? After knee replacement, you have to have physiotherapy, which doesn't need to be given at the hospital. It can be given at a lower level. So all that kind of forward and backward linkages need to be established. And I think that is one of the unfinished agendas, that firstly, having stronger, well-staffed health and wellness centers, and clearly linking that with the tertiary care, I think has to be done.
Joy, as you look at just the metros and the large cities, have they been better from a private sector perspective at establishing this continuum of care and the feedback? Are you seeing, of course, 5-6 years ago, the large hospitals were mostly tertiary care. Many of them are now thinking about, look, I don't want to lose the patient. I want to be end-to-end, from primary to secondary to tertiary care. what are you seeing hospitals think differently about or do differently?
So, if you see from the time of COVID especially, and the kind of private funding has started coming, and especially metro cities or tertiary, tier 3 cities have been, saturated with the private providers. Many of them are opting out to go to, tier 2 cities also, and trying to create some sorts of, facility. And as Dr. Suchin mentioned, I have seen many of them are trying to target the segment of not only Ayushman Bharat, but even schemes like CGHS or other reimbursement schemes, which are not really very much well accepted in the hospitals in the metro, private sectors today. I'll tell you the reason that it is not that it can't be recreated or it can't be done, but each one of us have some sorts of target audience or the market what you want to cater to. So if I have that market in my that particular hospital, and if I try to get generic medicines or a different kind of model altogether in my hospital, I'll be diluting my brand. And sometimes I may land up in doing something which may not be accepted even by both the sides. Like I may make a mistake of using something for a patient who is coming under this scheme, and things become different vis-a-vis for a patient who is coming for a high-end, high-quality care and looking for best of the class things.
But even if you don't use generics, can you triage the patient differently? So to Nachiket's point, can you triage them differently where a normal delivery doesn't come to the tertiary care center and goes to a secondary care center versus you at maybe Hinduja in Mahim seeing the more complex cases?
See, first of all, the particular example what you have taken that we don't take up in Hinduja, we don't have the obstetrics facility. But to answer in generic for all the hospitals, I must tell you, we have very limited choice in terms of selecting these kind of patients. We have physicians, doctors who are attached to the hospital, they are generating their own patients. Now, a person who is so-called very less risky or who can be managed in a different kind of setup, the doctor doesn't want to lose them. And it is their clientele base whom they are getting into the hospital. So even if you want to tell them that you don't come, I'll tell you even before COVID, now I'm taking example of our own hospital, we are operating in a 90% plus occupancy level. And during this season, July, August, September, when we had a lot of these malaria, dengue kind of cases, they started coming and landing up in our hospital emergency. And at that point of time, we didn't want to entertain because it is a high grade fever and some of the symptoms which could have been easily managed in a different setup, but they wanted to come because in normal circumstances they are our patient. So though we want to send them in a different facility, but they are not much agreeable to accept that term. So as a result of that, we need to handle. If you ask whether we are keen to do that, yes, probably we want to handle only the high-end cases and a different kind of mix of patient. But when we are like a community hospital and cater a particular community, we can't be very choosy at that point of time.
Understood. No, I think I can take an hour with each of these panelists and we still won't get enough. But I do want to keep a few minutes for questions from the audience. But before that, I want to do a little bit of a rapid fire on a couple of questions. Perhaps each of you can take a minute, which is again highly constrained, so I apologize. Yes, my first question is NDHM. Is it hype or reality, and why?
Well, NDHM, reality, of course, but it's something, if we continue the momentum, it will do the same thing to the health sector that UPI has done for finance sector. It will be a big game changer, transformational initiative, which is there. And actually, the benefit of implementing it much later is that we have learned from the mistakes of other countries. And so in terms of putting in place a system which is interoperable and learn from the latest technology, I think is benefiting us. But before we go too far, we also have to realize that UPI took 11 years before it became actually operational. And also it had, I shouldn't say benefit, but because of demonetization, probably it got a lot of momentum. And so we are also, of course, looking for some similar type of thing which will provide a positive shock in terms of its acceptance. And also a little bit, I see resistance from some quarters, because in UPI, all the people, all the stakeholders were aligned. Their interests were aligned. Banks wanted to have it. Consumers wanted to have it. The commerce people wanted to have it. E-commerce was very keen to have it. In the health sector, there is a asymmetry of information, and hospitals, and I'm no disrespect to you gentlemen, but hospitals and doctors keep asking the question that what is in it for us?
Got
And
it. Joy, hype or reality?
I think till 24 hours before, if you'd have asked this question, I would have told, and in most of the cases I have told, that there is existence of India and Bharat, but now it is only Bharat. So why you used to tell? Because there is a huge contrast. And is it going to happen? So in several discussions we have told this repeatedly. There are three things involved in this. The first, a lot of questions about its implementation. While maybe some of the big hospitals who can afford, if we are willing to do that, can do, many of the mid and small size hospitals are asking, how do I do, who is going to help me, on what basis it is going to happen. The second thing, as Dr. Mentioned, Dr. Indubhushan, that what is there for me? Let me tell you, when this was in the blueprint stage, as a part of CII, I was required to conduct some of the sessions where I called some of the hospitals. They asked me this question point blank because there was no one else. And they asked that, what is there for me? Why should I do that? And the third and very important part, I feel, lot of fear in terms of the data privacy and how your data is going to leak, as because, to be very honest.
It's interesting you say how it is going to leak as
Yeah.
opposed to if it is going to leak. But
So I'll tell you why, because everyone is worried about the treatment protocol and guidelines. It is not a standardized one in this country as yet. So what I do, it may not be the right one in the view of the other person, and in that case, my reputation is going to be at stake.
Understood.
So, a lot of...
Dr. Suchan?
I think a lot needs to be done to make it into a reality, but I'm very hopeful that it will lead to a lot of positive things for everybody, including us hospitals, and we will very quickly find out what is in it for us. But I think, see, compared to the sheer number of patients that we treat, we are notoriously poor at producing and analyzing data, right? We rely on Western data for most of the things that we do. We will prescribe a medicine to a 5'2" person living in Bengal eating a rice-based diet on the premise that it will work as well for you because it worked on a Caucasian who's living in the east coast of America having a meat-based diet who's 6'2" tall. Because that medicine worked for him, it will work for you as well. So that is what we do currently. So the amount of data that will come out of this, the amount of data that we'll analyze, the preventive healthcare that Dr. Moore talked about, that if we can actually put all the things and the risk factors of these diabetics, the 35% that he is presuming will become, and analyze that 10 years later, these were the 3 things that were at risk which led to kidney failure, so that we can actually make better interventions in people who have those 3 risk factors. I think those things will work a lot for us.
Nachiket?
My sense is there is really no choice for hospitals now but to automate. We are 25 years behind. I mean, when I go to the US, many doctors have never used paper. can turn to and say that if you're automating, follow these standards. That automatically gives you interoperability, that automatically gives you many things. And to this question of what is in it for us, insurance industry is now gradually moving to a framework. It will take time in which there will be automated processing of insurance claims. If a hospital is not automated, they will pay that price in delayed claims processing. And they will build up account receivables that will not necessarily go away. So, one is the data analysis. I don't really see that there is a choice. People will have to go there. Once they go there, the NHM standard will start to have a very powerful impact, because an insurer will say, unless you give me the E-object in the standard given to me by NDHM, I'm not going to process the claim. Right? So it's a real opportunity, I think, for early movers. But I think it's an early mover, late mover question. I don't think the issue is of choice. And I'd be very surprised 5 years later if I'm carrying to a hospital a fat file. It's just, this is some Stone Age stuff that we'll have to get rid of.
I had one more rapid fire, but I'm going to hold it, just given that we have only about, we can see 4 minutes and 15 seconds left. So maybe open it up to the audience. Sanjay?
So, great interaction. Thank you for the lovely questions and great answers. I have a comment or a view on every point that has been spoken, but let me pick the last one, that what's in it for the doctor. And being a doctor myself, I can give you 50 reasons on why automation or digitization should be there. I think the first and foremost is patient longitudinal data allows me to treat the patient better. I'm just making a statement. We can discuss this further. There is so much to be gained by just having the longitudinal data of a patient to know how he or she is trending over the last so many years. The point I wanted to make, which is different, was, and I think Dr. Moore also brought it up, said, let's take Kerala as an example, where you said that well-managed, tiered healthcare system, yet nobody goes to the primary healthcare or the intermediate. So I'm stepping back and saying, why do people go to Kota for education? Does it mean that we don't have schools and colleges in any other parts of the country? So I think the same problem, which is not being addressed, and to you, sir, is that healthcare education, healthcare skilling, so both in the medical fraternity as well as the paramedical staff. And you spoke about it, that if there are adequately staffed primary healthcare centers, I think one of the reasons why 150,000 primary healthcare centers have not been set up is because we don't have skilled staff to manage them. So what is the government trying to do to make healthcare education overall better quality, more standardized, and what are we doing to allow paramedical skilling to become aspirational? Today, we run a paramedical training institute where people don't get anything else, then we have to go and tell them. We only go to people who don't get above 60% because they don't get anything else, that this is an opportunity for you. Nobody wants to do this voluntarily and saying, I want to be a paramedic or I want to be a nurse. If they want to be a nurse, they want to go to US and earn $80,000 instead of 3 lakh rupees out here. But nobody wants to do it voluntarily. How are we going to change this ecosystem? How are we going to get better trained doctors? How are we going to make access? There are only 6,000 radiologists in the country today for such a large country. Why are we not increasing radiology seats?
Maybe we'll get Dr. Bhushan to answer that. You have 1 minute and 19 seconds before that rocket launches. Yeah. Is there any other question, please? We can just get to the question and then we can.
Absolutely. Let's look at an idealistic situation. When we talk about Ayushman Bharat or One Health, literally every citizen in the country is vulnerable from health perspective. So although the end goal of Ayushman Bharat should be that we look at a scenario to upscale it where every individual gets benefited. And then to do that to that massive scale, you need a lot of funds and a lot of money to run such a system where the hospitals also are struggling in terms of the profits or the bottom line. So can we look at an ideal situation where somewhere it is linked to the tax that a citizen is paying, where when he is paying certain amount of tax, let you charge maybe 2%, 3% extra, he won't mind when he gets world-class health treatment in the country. It has two advantages. Those who are
Maybe if you don't mind my interrupting, maybe we can get to the
I hope you
should we tax? Should we create this as a tax and then also medical education?
yeah.
Yeah.
Basically, you will have a lot of non-taxpayers coming back into this scheme also.
Okay. So on the medical education, there are a lot of initiatives currently which are underway. One is that there will be medical college in every district. So there'll be a large number of new medical colleges which are being done, but also colleges for allied hospital persons, but nursing colleges. And in terms of but my own sense has been, all the data that I've seen, is that it's not a question of numbers. I think it's a question of quality and distribution. A large number of, you talked about 6,000 radiologists, and I've seen the same number for surgeons, but you would also find that 80% of them are in 8 metro cities. And just ensuring that we have a better distribution across states, across rural and urban areas is going to be a big problem. Again, of course, it's not an easy problem to solve, because if it was a easy, probably we would have solved it by now. There's a huge number of socio-economic factors which determine that. But I have a feeling that as the numbers increase, because large number of medical colleges and schools are coming up, I think the distribution will become slightly more equitable. But I think question is about the quality, because many of them coming out of many of these hospitals are like in other sectors as well, engineering, people talk about that. The quality has been of very uneven variety, and I'm hoping that the reform that has been done through NMC, National Medical Commission, and the focus also NDHM, we hope that that quality will also improve. And government is also thinking of a scheme where we can use our human resources for health for export, and that can also create some incentive for people to come in a field like nursing, where they could be going outside for 5 years and come back and serve in the country. And that is that kind of model that Philippines, where I lived for about 21 years, has very effectively adopted, where they have large number, most of the hospitals in all over the world have large number of Filipino nurses and doctors that could be used, and they go there on contract for 4 or 5 years and come back to the country after some time. So I think it's a huge problem, and that is the key, I think, for providing and ensuring universal health coverage. And that comes to the second question that you raised. Ultimately the goal is to have universal health coverage, and you're right that anyone who gets sick needs to be treated, whether they're rich or poor, and some rich people can afford it, but that is only a small amount, number of people, and there is a middle section who are not rich enough to get insurance, but they're not poor enough to get Ayushman Bharat. I think we need to focus on them as well. And I have a feeling that, and I can assure you that there's a lot of discussion and background analysis going on in terms of how to address this problem of missing middle. And I'm hoping that before the next elections, probably we'll also have some schemes for them. And your idea about adding this to the tax actually has been discussed. And I'll not be surprised if you see it very soon, that people who are paying income tax should have access to Ayushman Bharat. And if they want to add on to some of the specialized services, they can pay more, and they'll be, for example, in Ayushman Bharat, we give only general ward. If you want to have access to private ward, you can pay and top up that kind of discussion is already undergoing.
Thank you very, very much for a really engaging conversation.